Good afternoon. I'm going to present the 12-month progress of my PhD, which focuses on contemporary alignment techniques in total knee arthroplasty. So imagine in 20, 30, 40 years you have a painful knee and it hurts day and night. And you finally decide to undergo major operation, which is knee replacement, and your surgeon agrees. And you go to rehabilitation. You are 6 months, 1 year after rehabilitation, and your knee still hurts. So, to our knowledge, this problem affects about one in 5 patients to this day. And in our systematic review and meta-analysis, we found that the personalized kinematic alignment can actually improve this problem, actually improve some outcomes such as pain, proprioception, and function by 5 to 10%. So we do recommend kinematic alignment as a first-line option for patients undergoing total knee replacement. My name is Nándor Nemes, and I'm a third-year resident and first-year PhD student from Székesfehérvár. I am interested in the treatment and management of osteoarthritis, and I have a special focus on total joint replacements. In my PhD, my goal is to compare 2 techniques in total knee replacement, which are mechanical and kinematic alignment. My first project is a systematic review and meta-analysis, and my second project is a randomized controlled trial. So, as I've already touched upon, total knee osteoarthritis is a global problem. It affects over 300 million people worldwide. We perform an immense number of operations annually. It's one of the most commonly performed operations. And despite this clinical experience, there are still a significant proportion of patients left unsatisfied. Now, we still rely on a traditional method called the mechanical alignment. And why is it still so popular? It's an easy, nice technique, reproducible, and we know that it's safe. However, it disregards individual patient anatomy, as you can see on the picture. In direct contrast, kinematic alignment builds on this individual patient anatomy. So we want to know how they compare. Is the personalized approach going to lead to improved clinical outcomes? Just as a side note, people who like the kinematic principle but are afraid of the potential unknown long-term complications came up with a kind of a hybrid approach, the restricted kinematic alignment, which considers safe zone parameters. So does kinematic alignment, personalized technique, lead to improved clinical outcomes? We performed a systematic search in 3 databases with 300 results. In the end, we had 19 full texts to include in our systematic review. Now, this slide is showing some patient-reported outcome measures, which are based on subjective patient scores. The first is the Oxford knee score and the WOMAC score. Both are very similar scores. They ask patients how much pain they have during various activities, such as walking, climbing the stairs, lying in bed, at rest. The Oxford knee score is a 12-item score, WOMAC score, 24-item score. And WOMAC is an inverse score, so the lower the better. So anyway, we can see there is a modest benefit when we look at the Oxford knee score. However, in the WOMAC score, we can actually see a significant benefit in the unrestricted kinematic alignment group. And this trend, this pattern can also be observed in the Oxford knee score, where the unrestricted kinematic group has a higher score. In terms of function, so flexion is an important measure of function after the operation. We want to achieve better flexion, and in the kinematic alignment group, we have on average or overall 5 degrees more flexion after the operation, and this effect is even more pronounced in the unrestricted kinematic group. And in terms of forgotten joint score, that actually asks patients how much they remember or how much they are aware that they have an artificial joint on a scale of 0 to 100. The benefit is modest, but is relevant. In terms of safety, at 1 to 2 years, we can see that there is no significant overall risk in terms of revision. However, in the restricted group, you can see that there is a increased risk of revision by 3-fold. Now, I'd like to treat this result with caution because of the low sample size and low even number. And when we look at the overall pooled effect, the risk ratio is not significant. So in conclusion, we can conclude that in terms of safety and effectiveness, kinematic alignment is not inferior to mechanical alignment. Some patient-reported outcome measures and flexion actually favor kinematic alignment, especially unrestricted kinematic alignment. This is the first study to show that effect. And the restricted, unrestricted groups are two separate surgical domains. We can't pool them together, as previous studies have done. They should be considered separately, otherwise we don't see the reality. We, however, need further high-quality randomized controlled trials. We still badly lack the long-term follow-up results, and the future subgroups should examine the relationship of individual anatomy, the treatment modality, and the basic demographic parameters. We only included randomized controlled trials. We followed rigorous methodology and used pre-specified subgroups. However, as you could see in some outcomes, the included studies were low in number. For most studies, the risk of bias was uncertain or high. I think that's a serious limitation. And again, we still lack sufficient long-term data, which we will need. Now, I was privileged to present the results at the Hungarian Orthopedic Congress in June, and I'm going to Madrid in September to present these results. The manuscript is finished by my part. I've submitted to my supervisor. If he confirms, we will submit it for internal review. My second project focuses on comparing inverse kinematic alignment and mechanical alignment in total knee arthroplasty. So having done the meta-analysis actually inspired me to run and do my own randomized controlled trial. And with the coming of new technologies, such as robotic-assisted total knee replacement, we have new techniques as well, such as the inverse kinematic alignment that was first described in 2020. We don't have a direct comparison of inverse kinematic alignment and the gold standard mechanical alignment. Therefore, I'd like to see how they compare. And whether this new, still relatively expensive technique is worth its money. In summary, I'm focusing on comparing two techniques in total knee arthroplasty that are kinematic alignment and mechanical alignment. And I'm planning to finish both projects by the end of this year, hopefully. I'd like to finish by a quote from Rodney Smith. We have to bear in mind the best possible operation is not the same thing as the best operation possible. Thank you.
Congratulations on your presentation. My question would be that what are the causes of revision after 1 or 2 years after the primary surgery, and how often is it among the patients?
Yeah. So at 1 to 2 years, the reason for revision is either infection, so either the patients develop deep infection that is probably unrelated to what alignment they use in the surgery. However, another major cause of revision would be the aseptic, non-infective loosening. So that's one of the major critics of kinematic alignment say that because it's put in a certain way, it will lead to unequal loading on the prosthesis, and it will lead to loosening of the implant. In these studies, I actually don't remember what were the specific causes, but overall, these are the two main causes.
And have you taken into account these, let's say, co-founding factors? Because if a patient has another comorbidity, let's say diabetes, it's more likely to have infection. Yeah,
that's true.
So
well,
how did you handle this?
I guess why we included randomized controlled trials, so they try to, take into account these confoundings. So yeah.
Okay, thank you very much.
Thank you.
Thank you very much. So, do we have any Hungarian data regarding of each type of surgeries?
That's a very good question, and actually, potentially a third project. I had provisional approval, but I'd like to run a registry analysis on the Hungarian prosthesis registry. We don't have a registry analysis yet, but we have lots of data. So I'd like to, hopefully I can have a look at the registry data. I'm afraid the registry doesn't actually register whether it's mechanical or kinematic alignment, so we won't specifically be able to look at that question. but maybe at the end of the study we can suggest to include this category as well. Yeah.
Yes, László Bucsi, orthopedic surgeon. Congratulations first. This subject is really revolutionary. Either using this kind of kinematic alignment or using the conservative, long-lasting mechanical alignment. You partly mentioned that in kinematic alignment, the force load on the prosthesis is not equal, but comparing to the mechanical one, the load force is equal. So in long run, in my mind, most of us think that the kinematic alignment, prosthesis put in by kinematic alignment is going to be loose earlier than the mechanical alignment. So you have to be careful to select the patient. What do you think about the BMI in patient selection? This is number one. The other one is this robotics. At present, no significant difference between the robotic use and non-robotic use. But in long run, because the robotics can be precise, more precise than without robotics, so in long run, probably the robotic use is much more useful and recommended to use, and we can see the long run result.
Thank you very much. So back to your first point, BMI and loading on the implant. So we couldn't pool data on this outcome parameter, but actually 2 studies had a look. What do actually implants look like when patients stand, so like real life? They looked at long standing radiographs and they measured the angles, and actually it turns out that in the kinematic alignment, the joint line is actually more parallel to the floor compared to the mechanical alignment. So in theory, actually that actually might lead to better load distribution, but we will still have to study that outcome parameter. Yeah, that's it.
There is another question.
So after seeing your presentation, it seems like that kinematic alignment is a bit better than mechanical in patient-reported outcomes. But he said that it could cause early aseptic loosening. Yes. But that's not coming in the first 2 years. So I think we should look into like 5 years, 10 years or something to say. Yes. So I would like to ask that, would you like to include 5 and 10 year long?
They are included
in your no.
Yeah.
In your RCT.
Yeah, definitely.
You want to or you should?
Oh, 100%. 100%. Yes. Okay. Yes, definitely. And there are long-term outcomes in this study as well in my systematic review, which I couldn't pull into the meta-analysis. So yeah. And they suggest no significant difference up to 10, 13 years. Yeah.
But you don't have enough data to meta-analyze that.
That's right.
Yeah. So you need more data
yes.
to be sure.
As mentioned.
Yeah.
Thank you very much.
Thank you.